Hi, good afternoon, and welcome to Good Samaritan Facebook Live. My name is Adam Thacker. I'm the Chief Operating Officer here at Good Samaritan. I'm joined with Dr. Jane Bridges, our in-house diabetes specialist, and that's going to be our topic for today. We're going to talk about diabetes and what you as patients or just being informed community members can do to make sure that you're identifying risk and concerns, and then certainly our Good Samaritan team to get you linked up with specialists such as Dr. Bridges. And I'll just kick off a little bit saying, why is this important? And when you look at the stats, we've been in the last 18 months talking a lot about COVID, and that's kind of been this center focus. But what has been overshadowed somewhat is chronic diseases, and especially those like diabetes, because some heart and lung have really been amplified because of the risk with COVID. But diabetes is just a massive chronic disease. Looking at the American Diabetes Association, 34 million people living with diabetes.
Yep.
And this was the stat that just kind of blew my mind, and I tried to do a little research on this. 1 in 5 don't know they have diabetes.
Yep.
So we're not getting that message out there for people to really feel compelled to, hey, this is something I need to be on top of, and hopefully we'll give some information today that that gets them thinking about it. So why don't you kick off with a little bit of what your training is and why you're the specialist they should listen to.
They're still not going to listen.
Well,
but okay.
some might.
I'm Dr. Jane Bridges. I'm a clinical diabetologist. I trained a little differently. I boarded in family practice, but then went back and did a 2-year diabetology fellowship at Indiana University. And so was looking for a job, and Dr. Stewart and Dr. Combs recruited me to this area. So it's going to be 30 years next year. So I've been here a long time.
That's great.
So Adam, this is Diabetes Month. That's why we're talking diabetes. So in regards to that, and you're right, 1 out of 5 who have diabetes don't know they have it. So just to kick off, there's a current trend happening, and the trend is in regards to screening. And they're wanting us to screen patients now earlier. So the Prevention Task Force is wanting all patients by the age of 35, if they are overweight, to be screened for diabetes. And screening is easy. Good Sam does a lot of screening out in the community. And also the ADA is even more aggressive in regards to screening. They want all patients who are overweight or obese to be screened. So if, say for instance, you're an 18-year-old, and you are overweight or obese, it is time to be screened at that time, especially if you have a family member with diabetes or you lead a sedentary lifestyle. So the trend now is screening much earlier so we can identify that 20% who have diabetes but just aren't aware. Because what happens when you don't know that you have diabetes and you sit on it for 20 years, by the time you see someone like me, now you've got complications that could all, as far as I'm concerned, been prevented.
Right. And I think there's a really key element in the screenings that we offer, and we'll get into the detail of kind of how screening occurs. But this is such a silent disease state
Yes.
that creeps up, and so many people go on the my body will tell me when something's wrong. The problem is by the time that happens, we're so far down the road that this is a disease state that has irreversible damage.
Absolutely.
And once you start feeling it to the point that you're hospitalized or seeking physicians because you can't get out of bed, we're really far down the road. Unlike cancer that has stages, but there definitely are stages to diabetes as it continues to progress up some of the stats that we'll talk about.
By the time you're diagnosed, you've probably had diabetes 7 years. 7 years.
Wow.
So it is a silent killer. And that's why if you are overweight, sedentary, in front of that TV, playing on your phone all day, and have a family member with diabetes, please get screened much earlier. Take advantage of the community screenings or talk with your doc about being screened.
So jumping a little bit into screening, and Good Samaritan does offer screening opportunities, free screening, through many different avenues. You can look at our website and find that information. at different community centers. Certainly, we have two really big men's and women's tune-ups that we have a number of folks that come to. But what is screening? How does that work? What are we testing? What are we doing to get that information we need?
Typically, we screen with just a blood sugar, a venopuncture out of the arm. There are several ways to screen for diabetes. The easiest is a fasting blood sugar done at a lab without having eaten anything for 8 hours prior. Now, let's say you find that you have a fasting blood sugar of greater than or equal to 126. Don't panic. The test needs to be repeated again. So you need to have 2 tests to confirm the diagnosis of diabetes. And I'm sure on the second one, they're out jogging and starving to pass the second one. But if you had the first one was abnormal, pay attention. There are other ways to screen. Some doctors will order a 2-hour glucose tolerance test. Not the most pleasant test to do. But if the 2-hour is over 200, that constitutes diabetes. Or they can use what's called a hemoglobin A1C. This is it's a blood test as well. We do it with a finger stick. And if that is over 6.5, that would constitute the diagnosis of diabetes. However, there are a lot of people who have really low A1Cs and still have diabetes. So that's not a foolproof way to make a diagnosis. And so it's either a fasting 2-hour glucose tolerance test or an A1C. And then if, say for instance, it's not diabetes, but it's not normal, that's what we call prediabetes. So prediabetes would be a fasting blood sugar between 100 to 125. So let's say if you've had a fasting of 110, pay attention, okay? That's what we would call pre-diabetes. You're not being given the diagnosis of diabetes. You're not going to be discriminated against, but you are being given a nice a warning about paying attention and following up on a regular basis with regular testing. Now, if the 2-hour, if your doctor ordered a 2-hour glucose tolerance test and the 2-hour is between 140 to 199, again, prediabetes. It's not diabetes, but it means you're at risk. Okay? And so when you're given this diagnosis of prediabetes, it doesn't mean, oh, I'm good for another 20 years. It means this is the time to start modifying your lifestyle, taking a really hard look at how you're eating and what your activity level is, and changing your lifestyle. And that's the hardest thing for patients to do.
Sure.
They all want a pill. Give me a pill. But
seems like the easy solution.
Yeah, the easy solution.
Rather than I can't eat the food I want to eat or do what I want to do.
But the best thing you can do is alter your lifestyle.
Yeah, absolutely. And I think as you walked through those numbers, it can be kind of daunting. How do I remember what I need to do? The big point with screening is it's easy. We have all kinds of access points, the diabetes associations. There are all kinds of events for monitoring diabetes, and that's where the medical team comes in to help guide with are you in normal value? Do you have pre-diabetes? And here's some things we need to talk about. Do you have diabetes? And let's talk about a management plan. And I think one thing that we see so often with so many disease states, there's a diagnosis or a pre-diabetes diagnosis, and it's immediately, I'm going to make all these radical changes that are probably going to last 2 weeks.
2, 3, some go out to 3 months.
3 months.
Then the holidays coming.
They're much better than I. They last about 2 weeks.
Our holidays begin at Halloween.
Yeah. So how do you help our patients and anyone with the test result kind of recognize what lifestyle changes that we talk about can they make that are not so overbearing that they just say, well, I'm not doing that.
Right. So it can be very simple. If, say, for instance, you're carrying extra weight, and you might be on some apps that maybe you can follow or determine how many calories you're consuming. If you would subtract 500 calories per day, you'll lose a pound a week. And you'll change the trajectory of your health. So instead of thinking you've got to lose 10, 20, 50 pounds in a month, which is unreasonable and unsustainable, just make small changes. So 500 calories less a day. Now, I have a lot of patients who like to snack on these cheese crackers. You know, I'm talking about cheese crackers or peanut butter and crackers. A pack of those is 240. And so if they're eating 1 or 2 of those a day, it's like nix those. Okay, find a few snacks you can go without. People work in offices and there's always some lady has got a bowl of candy on her desk. Stop hitting that bowl of candy. You know, all that snacking adds up to 500 calories. Get rid of the snacks, you'll start to change the trajectory of your health.
I'm going to go back to my office and put candy in my bowl that I don't like, so just other people
There you
will
go.
eat it.
Yeah, like licorice or something.
Right.
Yeah, because I love licorice. So. All right, so there's some other things. There are really nice weight loss programs out there that I'm not opposed to. I am opposed to the extreme diets that eliminate a macronutrient altogether. A ketogenic diet would be that. And a ketogenic diet tends to lock people in. They can't have any carbs at all. And once their brain gets a taste of carbs, they can't stop eating, and then they gain all the way back. So I prefer to have a nice balance of fat, protein, and carbs. So there's nice proprietary products out there like a Weight Watchers or a Noom, or you could read books on the Mediterranean diet. I think all of those are healthy. They can be pleasing, not totally eliminating the good stuff that we all like to eat,
Sure.
and still allowing you to eat out and dine, which I think right now, in our current situation, being able to eat out again and socialize is really important. So we don't want to eliminate that. You can also work with a dietitian, and that would require a referral, usually from your family doctor. And so keep dietitians in mind. They oftentimes can be very helpful, especially patients who want to be told exactly what to eat. See a dietitian, they can help you with that. Some other things that are really simple to do is just start walking. And there was a really nice study that showed we need to be interrupting our sitting. And you're allowed 8 hours. The first 8 hours of sitting in a day, which is usually at our desk, are free. And then after that, when you go home from work and you're sitting in front of a TV, that's when you need to start interrupting the sitting. And every half hour you should get up, walk around the house, preferably not to the refrigerator, but walk, do something else, do the laundry, get some errands done, and then you can resume your sitting if you're watching TV. So if you're at work, try to interrupt the sitting every 30 minutes. Makes sense, okay? And then think about just walking in our parks. I know right now with the time change, I've saw people trying to run in pitch black, wearing black, and here I'm coming up the driveway. It's like, oh my gosh. So it's not safe to be walking and running right now because it's so dark out. But if you can get out during the day, get to your parks, get to where it's safe for you to walk and be with nature and breathe fresh air. That's always incredibly helpful. Don't forget our why. We have pools and swimming are such powerful exercises. And so don't forget water exercises, especially if you have bad backs, hips, and knees, which a lot of my patients do because they're elder and overweight. The joints start to go. And so keep water exercises and swimming in mind. Biking, I think, is incredibly helpful. Anymore, I'm getting scared to bike because of falling. So stationary bikes for those of us who are scared. But bikes can be incredibly beneficial in keeping our legs strong. But most importantly, do what you like and do it safely. And so 500 calories, a little bit more activity, voila, you're going to change the trajectory.
Yeah, and I think important message is it's not prescriptive to the point of you have to follow these steps. Mm-hmm. There's so many approaches to it to make it fit your lifestyle, and that could be that your walking is more of an evening, it could be more of a morning, it could be somebody that likes to bike, or I'm really glad that you mentioned swimming and pools because here are so many patients that we talk to about exercise, nutrition, really make an impact on all chronic diseases. Mm-hmm. And you hear, well, when I start exercising, my back or my knee or my shoulder, but there are non-impact types of exercising, some of that being swimming, some of that being, instead of a regular bike, the recombinant bikes that are, just easier on the body. If somebody's motivated in making a change, there are definitely ways, nutrition and exercise, that we can guide them to get an answer that works for their lifestyle.
Yeah, be a Diana Nyad and find a way. I mean, do something to change your current life and you'll change the trajectory of whether you develop diabetes or not, or how you manage your diabetes. It doesn't take much, but just consistency.
So we kind of talked pre-diabetes and even early onset diabetes. Here are things that patients need to make a change that they really are the owners of. Yeah. Now, where you come in and experts in the medical field are, that's not enough or that's not working. And let's talk a little bit and educate on just from a treatment and how you monitor your diabetes as patients, and what you walk them through as a physician guiding them along.
If we can do that. Sometimes it's not easy,
Yes.
Adam. We struggle every day. But I think the foundation of taking care of your diabetes or even prediabetes is education. And when doctors are struggling with helping patients, frequently the patient just doesn't know any better. They just don't know. And they'll tell us, well, my wife has diabetes, so I know. Or my wife's a nurse. I always get that. So, but you're the patient, you still need your own education. So one of our initiatives that we've been working on to try to help everybody get their A1Cs below 9, because we're graded on that right now,
Absolutely.
is education. And many patients say, I can't take off work, my insurance company won't pay, I don't have time. So we've tried to make it as easy as possible. And I don't think we can get it any easier because it's free and it's in the convenience of your own home, wherever you have your computer or your smartphone. So we've recorded a 3-hour diabetes educational session. And this is the same session I do live for my patients. And so it can be accessed at www.gshvin, so Good Samaritan Hospital Vincennes, .org, and then /diabetes. So all you do is just log on. There are modules. You go through the modules. At the end of the 3-hour course, you get a certificate that you can take to your doctor and say, hey, I've had some basic ed. And so I do play the dietitian role, which I've never done before, so did the best I could. But I, again, give my philosophy about food and our approach to food. So we're hoping that all patients in this area who have diabetes, or your family who needs to know about diabetes, because diabetes runs in families, would take advantage of this educational process. So education is the foundation. And when patients aren't educated, it's much harder to help them go in the right direction. Another initiative, and that I think is monitoring, a revolutionary way of monitoring patients, is with glucose sensors. And it has changed everything for me. I no longer have to guess so much, because patients come in with one blood sugar and expect me to adjust the insulin. And it's like, you're not paying me to guess, and that's what you're asking me to do. And it's dangerous to make a doctor guess, because doctors will go home, will sleep at night, but the patient could be harmed. So now with blood glucose sensors, and these are devices that you wear on the back of your arm or your belly, and they check they check glucose every minute of the day. And they're actually checking glucose in interstitial fluid underneath the skin. So it's not a blood sugar, as we say blood, it's interstitial fluid. And there is a little bit of a lag time and difference between a finger stick and a sensor, but it doesn't matter, because we're reading waveforms. And so it has revolutionized how we are managing diabetes. I mean, it's one of those big pivots in our world. So we have another initiative that we've made available to any and all patients with diabetes. You just need to talk with your doctor about this. But we have a sensor clinic, and the physician can refer the patient to the sensor clinic. We'll place a sensor on you, and you'll wear it for 10 days to 2 weeks, depending on what sensor we place. And that information is downloaded and interpreted, and I send it back to the primary care doctor with recommendations. So it's almost like a little mini consult that is included, really trying to guide the physician on what to do next. So that is another, I think, really important way of helping people go in a better direction.
And that technology, as you said, it's a complete game changer. And I think one key element to point out, prior to that, the finger stick drawing blood glucoses.
Yep.
Obviously, there's a finger stick involved with that, but also we'd see that being done every 4 hours, every 6 hours, on different frequencies. And you get peaks and valleys in those. And, is the patient taking it at the right time, post a meal or before a meal when they're supposed to? This new sensor technology is actually a continuous monitoring approach. So when you get that data, you can have, we'll say, absolute trust, or as much as you can with any information that you're given, that is showing you a complete picture of of what the blood sugar, or in the interstitial fluid, what that glucose reading is.
Yeah. I mean, all through the night, you can see how many people are getting low and they sleep through it. And they'll tell you, oh no, I don't get low. Oh yes, you do. You're sleeping right through it. So we see how high the postprandials spike. We see when they're getting low, and now we can make appropriate adjustments of insulin or pills or whatever we're using. So we can customize that therapeutic regimen, bringing them under control, but yet preventing the hypoglycemia. So it is, like you said, an absolute game changer.
And sometimes when we talk about that type of technology, the immediate misperception is that, well, it'll be cost prohibitive. But what we have found is that a large number of payers do pay for sensors, not all, but even where not all do, there are affordable options.
Yes.
And really feel like, that's something that, one, we should try to get it covered by insurance, but then the manufacturers of those sensors sometimes have assistance programs that they will help with. So there are some ways to navigate what can be a costly disease to manage with the treatments and the monitoring.
Yes. Well, right now, fortunately, not unfortunately, July 17th, Medicare changed their rules, which was such a wonderful blessing because Medicare patients were required to test 4 times a day for 30 days. Well, they're not going to do that. So now Medicare just says if you are on 3 or more injections of insulin per day, you can get a sensor. That's wonderful.
Sure.
So most private insurance companies, most, not all, will cover sensors. And then if patients have some expendable income, the Freestyle Libre is an affordable plug and play. And that with the the little savings cards, around $75 a month for 2 sensors. Not too bad, being that many strips cost hundreds.
Right.
So it is a good deal, and we get so much information, and it's so helpful. And what happens is you can just put these sensors on patients, and they get their eyes open. They start to wake up like, oh my God, I had no idea. And they'll start to modify their dietary habits. They'll start to work on things. You don't have to do anything. They'll just bring that A1C right on down. So it's I love it that patients are engaging with them, and that's important. And then they'll come back and say, yeah, I now understand why you wanted data or more data. They can see why I was always begging for it.
Yeah, and more information not only is helpful with you and medical expertise, but for the patients as well, because it's about engaging the patients in their care. So it really does help with that.
We're looking for participation, not perfection. And so if we can get them to participate, then we can do a whole lot.
Great. Okay. So let's talk a little bit about complications and managing. So we've talked a lot about managing diabetes, but some of we talked a little bit of 1 in 5 don't know, and by the time they do, they're coming to the doctor. What types of complications do patients see from diabetes that would be concerning?
Okay. The leading cause of death is cardiovascular disease. So that would be strokes, heart attacks, or poor circulation in the legs. And so in addition to controlling sugars, we have to control high blood pressure, and we have to control bad cholesterol. And so those are the 3 main components of trying to reduce one's risk of cardiovascular disease, and in addition to getting people to stop smoking. Okay, so those are the big ones. And that's what we call macrovascular, the big vessel complications. Then we have the microvascular complications, and these are the complications that involve the little tiny blood vessels that are in the eye, in the kidney, and that go around the nerves. And so you'll see diabetic retinopathy, diabetic nephropathy, which is kidney disease, and diabetic neuropathy in the feet. And again, with the microvascular complications, the number one thing to do is control blood sugars. A lot of people want to fix for this, and this, but they forget to fix the underlying cause of the complication, which is hyperglycemia. And I'm a very glucose-centric physician. I'm going to always work on controlling blood sugars. And for that main reason, I'm trying to prevent the long-term devastating complications that happen down the road.
And certainly, as we've talked about management, if that's not connecting with some folks that are watching that have a diabetes diagnosis or in that group that may have that don't know, the long-term complications, just to kind of put it out there big and scary, is eyes, potential blindness, and our feet, and wound healing, and the potential for amputation, and even on a lesser scale, not being able to walk because of wounds on your feet appropriately, but it really does lead itself down the path to a very serious life-altering complications.
Right. And it doesn't have to be.
Right.
You know, let's take care of our health now and not wait for the bad stuff. Let's assume responsibility for our health care as early as possible and not wait until the complications do come along. Because I'm not one to talk about the bad stuff. I want to talk about, okay, the positive stuff. This is how we can go in a better direction and give you good quality of life with less risk of complications, especially the devastating ones, which, you know, heart's bad enough, but a stroke is incredibly debilitating and may mean nursing home and things like that. So I'm all into being aggressive early on and not dragging my feet with the patient. Although some patients want you to drag their feet. They you know, just give me, you know, another 3 months. I'll straighten up. And it's like, yeah, I've been waiting 2 years. Let's go. So.
Sure. And I think it's really a key point that you made there. You know, living with diabetes and the changes that, you know, once you have a diabetes diagnosis, can live a full, complete life with really zero impact to how you can live your life. There are those small changes, diet, nutrition, monitoring, your glucose, but ultimately it's not a death sentence, and it's not a life impacting disease state if it's caught early through the screenings that we talked about and monitored effectively.
Yeah.
Well, so I think as any closing remarks on diabetes, and then we'll see if there are some questions.
I have one more thing,
yes,
Adam.
Absolutely.
Right now is Medicare open enrollment. And the number one thing we have to deal with every patient is, I can't afford my insulin. This is a big deal. So for those patients who are on Medicare, please look for what's called the Senior Savings Model. And this is not in all Medicare products. So call your expert Medicare advisor or get on Medicare.gov, put in your zip code, and look for the products that have the Senior Savings Model. With this model, all insulin is $35 per prescription per month, even through the donut hole. Even during the deductible, it's all $35. So this could solve a lot of the frustration we have in trying to help patients. And so, you know, during this open enrollment time, please talk with your advisor or do some research on your own. It's called Senior Savings Model. And then the final thing is we're having some problems accessing insulin. It's not available.
Right.
So, don't wait till the last minute to fill your prescription, because your pharmacist may say we don't have it. And insurance companies are not always being forgiving. They're making the patient pay more for an insulin that is not on their formulary, even though it's not available. So just heads up, make sure you don't get your insulin at the last minute, because we have some access problems. So that's what I wanted to conclude with.
Okay, thank you.
Thank you.
All right, Tiffany, do we have some questions?
We have a couple questions that are both similar. They're wanting to know the differences between type 1 and type 2 diabetes and the differences in managing both types.
All right. Type 1 diabetes is a disease in which the pancreas is no longer making insulin. So these patients must take insulin to survive. If they go without insulin, they can get deathly ill and die. So that's the difference. Type 2s can be on diet, exercise, pills, or they may need insulin. But going without insulin probably will not take their life. It'll just make them sick, but not die from that. So they are managed differently. Type 1s are always going to be on insulin. And type 2s, again, can use pills. We have injectable hormones that we can use, and then insulins.
Okay, that looks like it's all the questions.
Okay.
Excellent. Well, I appreciate your expertise and your time in educating us on diabetes and the awareness of the disease, and really just sending that message that it is manageable. We have a healthcare team here that can work with patients. I know one thing that you said, you're a specialist in diabetes medicine, and that's where you focus your practice, but you can't take care of every diabetic in the region.
Nope.
So engaging with primary care physicians, having a primary care provider, making sure that those annual screenings are happening either through an employer or through our free free screenings, and then we have a team here that are ready to help any individuals manage this disease state. All right. Well, thank you everybody for tuning in to our Facebook Live, and we will be on here again next week.